Welcome to the deep dive. Today we're tackling, well, a pretty intense topic, using some detailed revision notes, cluster headaches.
Intense is definitely the word.
Right. So our goal here is to really break down these notes, pull out the key stuff you need to know. Maybe you're prepping for the MSRA, or maybe you just need a clear picture of this condition. We want to make it memorable.
Absolutely. And it's crucial because, as the notes point out, these headaches are unbelievably severe. We're talking excruciating, one-sided, recurrent pain. They even call it the suicide headache sometimes.
Yeah, that nickname really grabs you, tells you something about the impact.
It does, and understanding it is vital. Misdiagnosis is common, unfortunately, which means people suffer longer without the right help.
Okay, so let's dive in. We'll follow the structure here, look at the definition, causes, symptoms, management, the whole picture based on this material. Ready to unpack this?
Let's do it.
All right, starting right at the beginning with these notes. What exactly are we talking about when we say cluster headache?
Okay, so fundamentally, it's defined as a primary headache disorder. That means it's not caused by something else, it is the condition itself. But the key things are, it's severe, it's recurrent, meaning it comes back, and it happens in these cycles, these clusters.
And the pain itself is very specific, yeah. The notes highlight it's severe, always unilateral, just one side of the head, usually around the eye or temple.
Exactly. Unilateral, it's a big one.
Yeah.
And yeah, often orbital, supraorbital, or temporal region. Piercing, boring pain, really awful stuff. Plus, crucially, it comes with what are called autonomic features.
Ah, yes, autonomic features. What does that actually mean in this context?
It refers to those automatic bodily responses. Things like your eye tearing up, your nose getting blocked, maybe sweating. But critically, these happen on the same side as the pain. Ipsilateral autonomic symptoms.
Got it. So pain on one side, physical reactions on that same side. That's a key part of the picture.
A huge part. And then there's the pattern.
Right, the timing. The notes mention attacks often strike at the same time each day, like clockwork.
Yeah, remarkably predictable sometimes. People can be woken from sleep, hence that nickname, alarm clock headache. These attacks happen frequently, maybe daily or multiple times a day, during a cluster period which might last weeks or months.
And then they stop.
And then hopefully they go into remission for a time. The attacks themselves, though, despite the intensity, are relatively short notes, say 15 minutes to 3 hours usually.
15 minutes doesn't sound short when the pain is that bad, I imagine, especially multiple times a day for months. That suicide headache name, it really lands differently when you hear the details.
It really underscores the impact on quality of life. It's utterly debilitating.
Oh.
And recognizing this whole pattern, the pain type, the autonomic signs, the timing, that's how the diagnosis is primarily made. It's clinical.
Though you'd still rule out other things, presumably.
Oh, absolutely.
Hmm.
Always need to exclude other potential causes.
I see some other names in the notes here. Migrainous neuralgia, histamine headache.
Yeah, those are kind of older terms, maybe reflecting earlier theories. The important classification now is that they belong to a group called the trigeminal autonomic cephalgias, TAXPs for short.
Trigeminal autonomic cephalgias, taxis. Okay, what does that classification tell us? Why group them like that?
It actually describes them perfectly. Trigeminal points to the trigeminal nerve that's the main nerve-carrying sensation, including pain, from your face and head. Autonomic refers to those physical signs we talked about, the tearing, redness, nasal congestion. And cephalgia is just the medical term for headache.
So headaches involving that nerve and those automatic physical signs.
Exactly. And grouping them this way is important because it separates them from other headache types, like migraines. Migraines usually don't have that same prominent cluster of ipsilateral autonomic features. So that immediately raises a key question for diagnosis. How is this different from a migraine, even if both can be severe?
Right, it's that specific combo.
Yep.
The pain characteristics plus those very particular autonomic signs on the same side, plus the timing. So for revision, maybe remember, unilateral pain plus autonomic features, ipsilateral, plus distinctive timing clusters.
That's a great summary.
Now, the notes mention two types of cluster headache.
That's right. It comes down to the long-term pattern, episodic versus chronic.
Okay, what's the difference according to the notes?
So episodic is when you have these cluster periods. They can last from a week up to a year, but they're separated by pain-free periods, remission periods.
How long does the remission need to be?
There's a slight difference in definitions mentioned. NICE guidelines say at least 1 month pain-free. The International Headache Society IHS criteria say 3 months or more. But the point is, there's a significant break. The cluster periods themselves often last like 2 weeks to 3 months.
Okay, and chronic.
Chronic cluster headache is when it's more relentless. The headaches persist for a year or more without a decent remission period, or the remissions are really short, less than a month according to NICE, or less than 3 months by IHS standards.
And the notes say chronic can develop from episodic.
Yes, that can happen over time for some people.
Okay, so the memory tip for types is basically about the remission duration over a year. Less than a month or 3 months break, think chronic.
Pretty much sums it up.
Now, the big why, etiology. What do these notes actually say causes cluster headaches? Is it known?
Well, like a lot of complex conditions, the notes describe it as multifactorial. A combination of genetic predisposition and environmental factors seems to be involved. It's not just one thing.
Is there a particular brain area involved?
Yes, this is quite fascinating. The hypothalamus keeps coming up. There seems to be some abnormality or dysfunction there.
The hypothalamus. Isn't that involved in, like, sleep cycles and body clocks?
Exactly. Which makes perfect sense when you think about that alarm clock timing of the attacks, right? If the body's master clock regulator is involved, it could explain why the attacks are so often cyclical and predictable.
That is interesting. The notes also mention something about blood flow changes and serotonin.
Yeah, those seem to be part of the downstream mechanism, what happens during the attack itself to cause the pain. Vasodilation, neuroinflammation. But the hypothalamus might be more involved in triggering the start of a cluster period.
Okay, so who tends to get these? What are the risk factors listed?
The notes point to a few key things. Gender is a big one. It's significantly more common in males. The overall ratio mentioned is about 3 males to every 1 female.
3 to 1. Okay. What about age?
Onset is typically in the 20s, 30s, 40s, so young to middle adulthood, usually between 20 and 50. But, it can start at any age, really.
Is there a family link?
Yes, having a first-degree relative, a parent, sibling, child with cluster headaches does increase your risk.
And lifestyle factors, smoking, alcohol.
Definitely. Smoking is strongly associated, increases risk, and also seems to worsen the severity and frequency of attacks. And alcohol is often a potent trigger for individual attacks, especially during a cluster period, particularly noted for triggering nighttime attacks. Lifestyle factors in general are implicated.
Right. So maybe a quick memory hook for risk factors. Male, 2050s, smoker, family history, alcohol trigger, something like that covers the main points from the notes.
That works, captures the key associations.
Let's dig a bit deeper into the pathophysiology. What's actually going on in the body during an attack, according to these notes?
It all seems to center around the activation of something called the trigeminal autonomic reflex pathway.
Okay, trigeminal autonomic reflex. Break that down a bit.
So think of it like this. The trigeminal nerve carrying that intense pain signal from the face gets activated. But its activation seems to also trigger the autonomic nervous system on that same side. This dual activation causes the release of certain chemicals, neuropeptides, which then lead to inflammation and vasodilation, meaning the blood vessels swell up around the nerves. And that process, involving the trigeminal nerve activation and the vascular changes, generates the severe pain and those autonomic symptoms like the tearing and nasal congestion.
And the hypothalamus fits in how?
The hypothalamus seems crucial for the timing, linking this whole pathway activation to the body's circadian rhythms. They've even seen specific activation in the inferior hypothalamic gray matter on PET scans during attacks.
Wow. And the notes mention stimulating the hypothalamus might actually stop an attack?
Yeah, it's mentioned as something explored, which really highlights how central that brain region seems to be. The vasodilation involves the trigemovascular system, and it's all happening unilaterally on the side of the pain.
But the notes also say the specific triggers for each attack aren't really known, and there's some uncertainty about parasympathetic nerves.
Exactly. It's complex. We understand the main players, trigeminal nerve, autonomic system, hypothalamus, vasodilation, but the exact spark for every single attack and all the precise nerve fiber involvement still has some question marks. So memory tip for pathophysiology. Think trigeminal nerve plus autonomic features plus hypothalamus link timing plus vasodilation, gun.
Got it. Now, differential diagnosis. If someone comes in with that severe one-sided headache and maybe a red, watery eye, what else could it be? What does the source list?
This is super important, obviously, to avoid missing something else. The notes list several key differentials. Migraine, of course, tension headache, then other attacks like paroxysmal hemicrania and SUNCT.
SUNCT. That's the short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing. Quite a mouthful.
It is. but the name tells you a lot. Also on the list, sinusitis and TMJ, temporomandibular joint disorder.
Okay, quite a range. So how do we tell cluster headache apart using what we've learned?
Well, you go back to those core features. You ask yourself, how does this presentation compare? Is the attack duration right for CH, 15 to 180 mins? Migraines are typically much longer, hours to days.
Hmm.
Tension headaches are usually milder, bilateral, and lack those strong autonomic features.
Right.
Paroxysmal hemicrania also has unilateral pain and autonomic signs, but the attacks are way shorter, just minutes, and much more frequent. SENCT is even shorter, more like electric shocks, but again has those prominent eye symptoms. Sinusitis usually comes with fever, facial pressure, maybe thick nasal discharge. TMJ pain is often related to jaw movement, so you're constantly comparing against the CH profile. The severity, the unilateral location, the specific duration, the ipsilateral autonomic signs, and that characteristic clustering pattern.
Okay, that makes sense. So the memory strategy is contrast the current headache against the classic CH features unilateral, severe, specific duration, autonomic clusters.
Precisely.
What about how common this is? Epidemiology. Are cluster headaches widespread?
Actually, no. The notes state they're considered rare. UK prevalence is estimated at around 0.1%. Globally, maybe 1 in 1,000 people.
Only 0.1%. Wow. And the demographics we mentioned earlier hold up here.
Very much so. Predominantly affects men. Typically starts in the third or fourth decade, often before age 30. The notes get more specific on ratios, too. Overall, male to female is about 4.1. But for chronic CH, it's even more skewed, maybe 15.1. Episodic is closer to 3.8.1.
That's a huge difference for the chronic form. What about the typical course of the illness over time?
Most people, around 80–90%, have the episodic form, with clusters coming and going, separated by those remission periods of months or longer. Progression to the chronic form is possible, and the notes link it to things like starting later in life, having attacks between clusters, more frequent clusters, or shorter remissions.
Any factors that suggest a poorer prognosis?
Things like a history of head injury, continuing to smoke, and significant alcohol use are mentioned as poor prognostic factors. But on the positive side, the condition often seems to burn out or at least improve for many after about 15 years, and remission periods might get longer with age.
Okay. So, key epidemiology takeaways. Rare, 0.1%. Strong male predominance, especially chronic. Young adult onset, usually.
You got it.
Let's really picture an attack now. Clinical features. What does it look like, feel like?
Okay, we've hit the pain highlights. Severe, excruciating, unilateral around the eye or temple. Duration 15 to 180 minutes. Happening maybe 1 to 8 times a day during a cluster.
And what's the person doing during an attack? Are they lying still in a dark room?
Usually the opposite. This is a key differentiator mentioned in the notes. People are often incredibly restless, agitated. They might pace the room, rock back and forth, sometimes even bang their head. They just can't get comfortable. Very different from the typical migraine behavior.
That sounds awful. And those autonomic symptoms, the ipsilateral ones, can we list them again from the notes?
Sure. On the same side as the pain, you'll typically see at least one of these. A red eye, conjunctival injection, tearing, lacrimation, a stuffy or runny nose, nasal congestion or rhinorrhea, a droopy eyelid, aptosis, a smaller pupil, miosis, and sometimes forehead or facial sweating on that side too.
So red watery eye, stuffy runny nose, droopy lid, small pupil, all on the pain side. It's a very specific cluster of signs.
Extremely specific. There might be some sensitivity to light or sound, but usually not as profound as in migraine. The notes also mention possible mood changes, fatigue, irritability associated with the condition.
Okay, so diagnosis relies heavily on recognizing this whole clinical picture.
Absolutely. It's primarily a clinical diagnosis based on that characteristic history and the features observed or reported during an attack. The notes lay out formal diagnostic criteria to confirm it.
Right, the checklist. Let's quickly run through that from the notes.
Okay. You need at least 5 attacks that fit the description. The pain has to be severe, unilateral, orbital, supraorbital, temporal, lasting 15 to 180 minutes untreated, accompanied by at least one of those ipsilateral autonomic symptoms we listed, or that sense of restlessness, agitation, occurring anywhere from once every other day up to 8 times a day, and, critically, not better explained by another disorder.
That's very clear. So a memory tip for features and diagnosis. Think criteria. 5+ attacks, 1,580 mens, unilateral severe pain, location. Autonomic features, same side. Frequency up to 8 day, rule out others. And maybe that RSMP mnemonic for the autonomic signs. Redness, tearing, stiffness, congestion, ptosis, pupil constriction.
Yeah, that covers the core diagnostic elements nicely.
So if the diagnosis is mainly clinical, what about investigations? What tests are actually done?
Well, the primary investigation is the clinical evaluation that detailed history and neurological exam.
What about brain scans, like MRI?
Neuroimaging, like an MRI, might be done, but the source is clear. Its main purpose is to rule out other things, to exclude secondary causes, like a structural lesion or something else mimicking the symptoms. The notes explicitly state that imaging is typically normal in primary cluster headache.
So you're not doing an MRI to confirm CH?
Exactly. You're doing it to make sure it's not something else potentially more sinister. Blood tests are similar, sometimes done for general health or to rule out other specific conditions, but not diagnostic for CH itself. It really highlights how crucial that clinical assessment is.
Right. And the notes list specific red flags to watch out for, don't they? Signs that it might not be primary CH.
Yes, and these are absolutely critical. If a headache starts very suddenly, like a thunderclap, if it gets worse with fever, if there are new neurological problems like weakness or numbness, cognitive changes, personality shifts, reduced consciousness, those are major warning signs. Also, recent head trauma, specific triggers like coughing or straining, postural headache, symptoms suggesting giant cell arteritis or glaucoma, or any really significant change in the pattern of headaches for that person. These need urgent investigation.
Definitely need to know those red flags. So investigations are mostly about ruling out secondary causes and red flags. CH diagnosis itself remains clinical.
That's the key message.
Okay, let's move to treatment. Once CH is diagnosed, how is this incredibly painful condition managed?
The notes break it down into two main strategies: acute treatment and preventive treatment.
Acute meaning for stopping an attack that's happening right now.
Exactly. And preventive is about reducing how often attacks happen or how severe they are over the longer term.
So for acute attacks, what are the main options listed?
Top of the list is high-flow oxygen, delivered via a non-rebreather mask, high flow rate, often very effective. Second is the triptan class of drugs, specifically subcutaneous sumatriptan, an injection, is mentioned as having a really good response rate, like 75% within 15 minutes. Nasal spray triptans are another option. Intranasal lidocaine is mentioned as maybe an adjunctive supportive treatment.
Are there other acute measures?
For attacks expected to continue for weeks, sometimes short courses of oral steroids like prednisolone are used. Ergotamine is also mentioned, taken predictively before an attack, but with a big warning you can't use it alongside triptans.
Okay. And what about preventing the attacks from starting? What's first line there?
Verapamil. It's highlighted as the main preventive medication for both episodic and chronic cluster headache.
Are there other preventatives if verapamil doesn't work or isn't suitable?
Yes, the notes list others like lithium, corticosteroids again, often a tapering course of prednisolone to break a cycle, and topiramate.
Do these need special monitoring?
They do. Verapamil requires ECG monitoring, especially at the higher doses sometimes needed. Notes mention 240-480 milligram daily. Lithium needs regular blood tests to check levels, plus kidney and thyroid function monitoring.
What about non-drug approaches? Things people can do themselves?
Well, oxygen therapy is often used at home, but a huge part is trigger avoidance. Identifying and avoiding things that set off attacks during a cluster period is key. The notes specifically call out alcohol, stress, GTN sprays used for angina, and sometimes exercise as potential triggers.
Get support.
Definitely. The notes mention supportive therapies like counseling, support groups, patient education. It's a condition with a massive impact, so that holistic support is important. Referral to a neurologist is recommended for confirmation and initiating treatment, with annual reviews suggested. Encouraging support groups is also part of it.
So it's a combination approach.
Very much so. Medication, trigger avoidance, lifestyle adjustments, psychological support.
Okay, quick management memory tip. Acute, oxygen, triptans, injection nasal, maybe lidocaine. Preventive, verapamil first line, then lithium steroids, topiramate. Avoid triggers, alcohol. Get specialist referral and support.
Perfect summary.
Lastly, prognosis and complications. What's the typical outlook for someone diagnosed with cluster headaches?
It's quite variable, as the notes indicate. Some people might have periods of remission that last years. Others might unfortunately develop chronic symptoms that are much harder to manage.
And it can switch between episodic and chronic.
Yes, that's possible in both directions. Stats-wise, the notes suggest about a quarter of people might only ever have one cluster episode. Maybe 15–20% develop the chronic form. And within that chronic group, sadly, 10–20% might become resistant to standard treatments. But there's some hope, too. For many, the condition seems to lessen in severity or frequency over time, often improving significantly after about 15 years, and remission periods might get longer if people age.
What about complications mentioned in the notes?
They mostly relate to the impact of the disease and its treatment. Side effects from the medications, obviously, but also the significant emotional distress, the disruption to sleep, work, social life. Basically, a major reduction in quality of life is a huge complication. But it's important to end on the note that proper management really can help. It can significantly reduce the frequency and severity of attacks for most people, even if it doesn't always lead to complete remission.
Right. So prognosis complications, memory point. It varies, can resolve, can become chronic. Complications include medication effects and major life impact. But good management helps.
Well put.
Phew, okay. We have covered a lot of ground there from these notes. Definition, causes, risk factors, pathophysiology, differentials, epidemiology, clinical features, diagnosis, investigations, management, prognosis.
Yeah, a pretty thorough overview. And I think the key takeaway, especially if you're revising, is just how crucial it is to recognize that unique clinical signature, that severe one-sided pain with the ipsilateral autonomic signs and the clustering pattern. It's not migraine. It needs its own specific management approach. Getting that diagnosis right changes everything for the patient.
Absolutely. So what does this all mean for you listening? It means locking in that pattern is key. Understand the pain, the associated signs on the same side, the timing, and know the difference between acute treatments like oxygen and triptans and the main preventative, verapamil. And here's a final thought, just based on how much the hypothalamus featured in these notes. Given that strong link to our body's internal clock, what does it suggest about how fundamental our biological rhythms are, potentially influencing even these incredibly specific and severe pain conditions? Something to think about.
Definitely food for thought.
Now, if you are revising and want more detailed notes and explanations like the ones we've been discussing, head over to MSRA.com.
Good resource.
And if you want to put your knowledge to the test with practice questions on topics like cluster headaches and many others relevant to the MSRA, check out freemsra.com.
Great for consolidating learning.
Brilliant. Well, thank you for joining us on this deep dive into cluster headaches.
Thanks for listening.